Good afternoon, everybody. My name's Matt Gonzalez, and welcome to our very first expert series brought to you by the Institute for Human Caring. Today, we are going to talk a lot about caring well through the end of life and our lessons from the pandemic. Just a few notes as we get started. All of you have been muted in this environment, but please feel free to use the chat box. We are here to answer questions, and we'll have some time near the end to be able to hear your questions and comments. And lastly, as probably most of you know by now, this presentation is being recorded. Just a note, I am not here by myself today. I am joined by my dear colleague, Dr. Ira Byock.
Here in person together.
For the first time doing a presentation in the studio in a very long time. It's wonderful to be here together to be sharing some of the things that we've learned. So
it's wonderful to be with you, Matt. And as we're entering the endemic phase of this COVID infection, it's time to take stock of what we've learned from the last 2+ years that we've lived through. I want to welcome you all as well and give you a brief introduction to the Institute for Human Caring, which may be new to a number of you. We are, at the Institute, a group of clinicians, educators, information technology specialists, systems change specialists as well, who believe that people of every age and stage of life deserve the best care possible for their physical health as well as their emotional, spiritual, interpersonal, and social well-being. And we contribute to both clinical and cultural leadership within and beyond the Providence Health System to transform healthcare and make caring for whole persons the new normal within this vision of health for a better world. Today, we will rapidly go through a number of slides and lessons that we have taken away from the pandemic phase of COVID. Things like the full hierarchy of needs and therapeutic opportunities that comprise human caring through human illness and dying. We will call attention to opportunities for positive systems change or to accelerate systems change through and during crises. Identify specific approaches, adaptations, and innovations that we have used to support goal-aligned care for people with life-threatening conditions, recognize resources for our own personal self-care and well-being, and know how to access resources for remembering and honoring our colleagues, patients, and their families. Early on in the pandemic, we realized that there were hard lessons that were coming at us that we were going to learn one way or another. This is a photo from one of our patients at Providence St. Joseph in Orange, California. We recognized that this pandemic was unprecedented in our lifetimes, that people coming to the emergency department were suddenly separated from their loved ones and might never see their loved ones again. That was first and foremost. The limitations of visitation was a hard-learned, painful lesson. The difficulties of having to do all of the work that clinicians do now within PPE and face shields and obviously gloves, being unable to enter rooms and the like was a serious challenge. We learned, I hope finally and forever, that health inequities, inequities of health outcomes were dramatic during the pandemic. This slide from April of 2020 showed in stark contrast the diminished outcomes, worse outcomes of people with color or Latinx populations. And that is one lesson that I hope we never unlearn. And we learned something that we should have learned long ago, which was that our direct care workers, the people working on the front lines of home health and nursing home care and in the realms of housekeeping and janitorial services, were at high risk, not only for getting the infection, but for unwittingly transmitting the infection from one person to another. Here's a direct quote from a slide from the Brookings Institute from Yvette Beatty, a 60-year-old home health aide. She says, quote, I am feeling scared. Saying goodbye to my family, I don't know if it's going to be that last goodbye. You're telling me before you push out these trillions and millions of dollars, you couldn't push this out for us? You couldn't push it out for these people who are on trash trucks, who are mopping floors, who are picking up bio waste, who are home health aides? We right here on the front line, we need you to open up. It is time to wake up and recognize us. Indeed. Well, as I talked with people who are colleagues and friends who have been on the front lines, and I asked what was the hardest aspect of this pandemic, they list both first, second, and third the separation of people from their families. What we thought was courtesies of visitation turns out was an important part of caring for people, to have the family support, to help them with their own sense of well-being, to help them with their orientation in time and space, to have a familiar, trusted, loving voice to listen to. We learned that we are going through this as well, that we in Providence see ourselves as whole persons caring for whole persons. We learned that burnout among clinicians, which had been epidemic prior to the COVID pandemic, was now universal. Burnout among clinicians, physicians, was in the realm of 54% prior to COVID happening, and now it is utterly ubiquitous. We turned attention early in this pandemic to developing or borrowing resources from other national organizations and collating them and making them available in just-in-time fashion in multiple ways to clinicians on the front line. The Providence team here developed something called No One Cares Alone, which is a suite of self-care services that clinicians can access at a moment's notice. There is a survey that can help you sort how much risk you are of true distress. And we made available to people just like that links to wise counsel and important opportunities for them to care better for themselves. In March 2020, Matt and I and our leadership team at the Institute had a meeting, and we said, this is truly a public health crisis. This is going to be with us for a while. What are opportunities within this crisis? You know, this is the Chinese character for crisis, made up of the character for danger and that of opportunity. And we try to alleviate or mitigate the dangers, but make full use of the opportunities to drive change, to drive value through highly personalizing care. We realized first and foremost that, again, the safety measures that were necessary, the lack of visitation and the PPEs, were separating us from our patients. And as people who see ourselves as whole persons, caring for whole persons, what could we do to reinforce that healthy paradigm? We borrowed this face behind the mask methodology that had been developed at another health system, and we created a template so that healthcare providers across the Providence system could print them in their local hospitals, put them in protective, transparent plastic sleeves, and wear them proudly on their chests to introduce ourselves to patients. We'll talk a little bit more about the Get to Know Me poster a little further on in this talk, but we already had developed this poster, which is intended to deliver patients from anonymity, and we accelerated dissemination and the use of these posters in various ways to help other clinicians remember that we are caring for whole persons. Early on in the pandemic, I thought hard about the things that I've been teaching over the years to hospice and palliative care providers about the full breadth and range of human caring through the end of life, and adapted that for my own sake initially on just a sketch pad about what that looks like now. And borrowing liberally and with appreciation and respect from psychologist Abraham Maslow, and maybe with a little bit of apologies to Dr. Maslow, I sketched out this pyramid of the full range of human caring. Notice that it starts at the bottom with the essentials, the human essentials. We know that we had to provide shelter from the elements, hygiene, something to eat, and something to drink. Most of these human essentials are not solely the work of healthcare. They are work that is shared collectively by community. We live in community with one another as human beings, not merely in proximity to one another. And so we worked collaboratively with so many agencies of government and nonprofits to convert open spaces to shelters to provide people with shelter from the elements and warmth and food and the basics. We did this in collaboration. We also wanted to help people feel accompanied, even though their families were at home or sometimes in the parking lot waiting for them to be admitted because they were unable to come inside. And we worked to do these things as the basics. Diagnosing and treating as the stuff of healthcare. It was made much harder because of the PPE and the lack of visitation and the need to prone people so that they could breathe better. And this was new. And we worked again here as teams safely turning people, getting those x-rays, the MRI scans, the blood draws, all of which was much more difficult now in this new healthcare environment, but we did it. Much of the work that we've done at the Institute for Human Caring is work on healthcare transformation, and a lot of it is to ensure that what we do for people honors what matters most to them. You know the old saying, it's not just what's a matter with you, but what matters most to you. And so again, we accelerated work in progress to develop tools and use tools to align what we do with people's personal values, preferences, and priorities. Here is something we call the Trusted Decision Maker Declaration. We had already been through governance at Providence to develop this tool, which is developed from a short form advance directive, but it's useful when people are unable to sign physically and when there is no witnesses or notaries available. Instead of the witnessing and notarization, there's a statement signed by a doctor, nurse, practitioner, or PA below a sentence that says the patient I'm speaking with today has verbally expressed their preferences, and this patient, by my assessment, has decisional capacity. And this is a way that we were able to honor their wishes that were expressed verbally to clinicians. I use this tool myself with multiple patients that I was seeing via telehealth. Mostly they were patients in an emergency department, many hundreds of miles from where I was sitting, but I was able to ascertain that they had decisional capacity and record their preferences for who they would want to speak for them and what their general preferences for care if they were seriously ill might be, and enter that into their health record.
Well, as I think about it, this is one of these key features that we learned very much over the course of this pandemic. Certainly 2 years ago, we were all pretty good at Zoom. We were pretty good at Teams. The reality is we've all had to become experts. And our patients and their families certainly have been on that journey with us. And one of the innovations I really think about this TDM form, this trusted decision maker, of being able to take in a verbal declaration and then to be able to witness it, is very much that it can be done in these virtual visits like you're talking about. We were able to bridge the geographic divide and even bridge the divides that we were seeing across hospitals and across regions. So I think it truly represents a step forward for us. Something that we will continue because our world is not becoming less digital. And frankly, I think the TDM form in its own version is a nice iteration on advanced care planning. One of the challenges that we've all had is notarization and witnessing, and recognizing that it's far easier for patients and families to be able to take this in and to be able to witness it verbally is very powerful and important. Now, that's just one step of the process, right? That's one part of the conversation that we often focus on. Another huge part of the process, as people have been seriously ill over the last 2 years, are conversations around what is meaningful when time might be short. These so-called goals of care conversations. Certainly, we didn't make this up. We recognize and bring from the Choosing Wisely campaign put out by the critical care societies and of the US. Both nursing and physician groups have endorsed very much that routinely engaging high-risk patients and their surrogates in discussions about goals of care and foregoing life-sustaining treatment and preferences is critical and important for all. Indeed, over the course of this pandemic, it's much more critical for the patients that we've seen, but a challenge, of course, given the isolation that we've heard about from Ira, the PPE, and trying to have these conversations, I know, through the multiple layers of masks and face shields and gowns and gloves is very isolating and challenging. Now, we at Providence, though, have recognized that while challenging, for the last 4 years, we have had a system-wide metric that looks to understand and looks to improve upon the percent of people who have an ICU length of stay of more than 5 days with a documented goals of care conversation. You might imagine that over the last 2 years, we didn't do well at this, but that is not true. We did very well at this. And one of the ways that we did well in this and amplified this is by doing this virtually. So here's a picture of one of our colleagues, Suzanne Engelder, who was working at our virtual pop-up Goals of Care Center. This was a center that many of us participated in to aid our frontline coworkers and clinicians, to be able to recognize that an ED person could quickly call us and we could Zoom into a room and someone could see us without a face mask, and we could have a very personal, intimate conversation about what their goals of care were when they were facing serious illness and COVID infection from the ER. Now, what are the outcomes of this? We've seen tremendous differences in terms of preferences for life-sustaining treatments and particularly a desired level of medical care before and after discussions. This is a series of all of the patients that we saw. Those before discussion, 83% thought that they were full code, full treatment, but changed to 61% after our discussions. And this wasn't because we were being overly harsh or convincing of other people. We were eliciting values, and that's important. Indeed, we see this not just virtually, but across our whole health system as we look at all of the goals of care conversations that we've had done by both palliative care consultants as well as hospitalists, nurses, social workers in our hospitals. We see that these goals of care conversations have deep and meaningful impact in the types of code status options that people choose. If you don't have any of these conversations, about 19% of the time in our system, we see that code status changes. If you have a primary goals of care conversation, we see it changing about 42% of the time, or about 35% with a palliative care consult. But layering both of these, adding on, being able to have multiple types and layers of conversation changes people's impression and the ability to interact and think about these things. We are seeing these conversations grow is the bottom line, and we think that they are doing really amazing work by having these conversations. Over the last year, we had 43,000 of these conversations across our footprint for a total of 107,000 goals of care conversations with seriously ill people across our health system. Now, one might say that indeed these are also showing improvement in work and patient experience. Here's a subset of those patients that we've been having the conversations with for the longest. Indeed, when we can show on satisfaction scores that when patients have goals of care conversations, their likelihood of recommending the hospital, the overall rating of the hospital, and degree that all staff show compassion are just a few of the 14 outcomes that we show better outcomes when having goals of care conversations.
You know, it's worth pointing out that in this graph, all of these goals of care conversations that we analyzed were done by non-palliative care clinicians. We actually took out of this data set those that were done by palliative care clinicians because we were interested in seeing, well, are we actually creating change at scale? And this is very reassuring to have a sense that those goals of care conversations are meaningful enough to have impacted patients in some way. You know, for years I've been teaching about end-of-life care and talking about how during the last stages of life, people have an opportunity not just to have their suffering alleviated, but to do work that's valuable to them, that work of life completion and life closure. And this is something that, of course, exists throughout all of life, and it's really common part of the human condition. And we saw it again during the pandemic, that within the crisis of illness and dying, which is, you know, the natural disaster facing all of us, despite the risk of suffering that we all have, which is real and deserves to be our first priority, there are opportunities that people value, opportunities to share bad news and sad feelings with one another, opportunities to say the things that would be left unsaid, to complete their business affairs and close their accounts and give their passwords to others, but also to complete their relationships, to say the things that would be left unsaid. That includes resolving previously strained relationships, perhaps between a married couple who were married for 20 years before a painful divorce, or good friends who fell out, or a father and son who had an argument years ago and now haven't spoken in years. When one or the other is now facing the end of life, often the bonds that connect us begin to look much stronger and more important than the infractions and the anger that has separated us. A chance to grieve together the impending loss of life and our future relationships. A chance to review one's life, to acknowledge how meaningful we've been to one another, to tell our stories if there's times, to explore those realms of meaning and purpose in our lives, as well as that sense of connection to something larger than ourselves. Perhaps it's God or nature, which will endure into an open-ended future. All of this is part of the human potential, if you will, to grow through the end of life. I focus most of my energies, certainly when time is short and people are facing likely at the end of their life, on making sure that there's nothing left unsaid. And I learned years ago and have taught for years the opportunity to say at least 4 things to one another before you're forced to say goodbye. Please forgive me. I forgive you, because I've rarely met somebody who feels that their relationship was perfect. Please forgive me. I forgive you. Thank you, and I love you. It's never too soon to say these words. And here's a gentleman with cancer, but during the pandemic, who was able to express those sentiments to his family at a distance. Additionally, I also learned early on in my work in medicine as a family doc and later as a hospice and palliative care doc, that this notion of well-being through the end of life is not simply pop psychology or, sort of woo-woo medicine, but really part of the human endowment. I learned this not from a book or something that I read, but from my dad. This is a photo of my dad, Seymour Byock, holding my eldest daughter, his first grandchild, Leela. I don't know if it comes through in the screen, but they have their eyes locked and they are ecstatic. My dad had pancreatic cancer at this time. He was within months of dying. Dad hated the fact that he was ill, hated the knowledge that he was dying. But looking at this, and I can tell you from spending so much time with him during these months, that my dad was also well within himself, well with his family, well during the time that we would consider him dying. I learned early on that relationships are essential for human well-being, and never more so than when people are in life-threatening situations. Here's a photo of a young mother meeting her neonate because they both had COVID, separated, but using the technology to see her young child. A family in Kirkland, Washington, just after the pandemic began, visiting with one another in a way that is safe, using, again, the barrier of the window, but visiting. A gentleman in Los Angeles who went on to die, unfortunately, visiting with his family using, again, technology for the most humanizing of purposes. Lastly, I also learned and have written about the importance and the sort of the pinnacle of honoring and celebrating life and relationships. This is something that, even mortality cannot take from us. We have the potential to honor and celebrate life and relationships through the end of life. That's part of the real purpose of these Get to Know Me posters. Yes, it is to deliver people from anonymity, but it's also to remind us all that we're caring for a whole person, somebody who has a full life, a rich life, and human potential even now. Even if they are unable to speak or tell their stories, they can be honored and celebrated. They can be waked out of life, to use that Irish term of a wake. You needn't wait till somebody has departed to honor and celebrate them. It's more fun when they're still alive, particularly if they can hear. Here's a patient, again, in Santa Monica, Los Angeles area, who had said he wanted to hear a mariachi band for the last time, and the team there made it happen. This is human caring to its pinnacle. People around the country learned, clinicians, including chaplains and clergy, learned that we can celebrate life and relationships even when we have to do so in a parking lot with a faith community that convened in their cars, or using our smartphones, doing it through windows if we need to. Here is a patient in Atlanta, Margie Ullman, who went on to die, unfortunately, but who was visiting for one of the final times with her family, and they were honoring and celebrating Mrs. Ullman through the end of her life. The technology was a barrier, and so many clinicians said, oh, it was terrible hard to hold that iPad and listen to those intimate, poignant conversations. I couldn't just set it up and leave because the technology really demanded that I be there to support it. There was no way not to bear witness and be present. But also note that technology enabled us to get to this full range of human caring, to allow people to know they will not be forgotten, that we love them, that we honor their memory, the privilege of being related to them, and we celebrate our family, our lives, and relationships. You know, when we began, we showed this Chinese character for crisis, danger and opportunity. We realized that during this crisis, there were opportunities, and one of them was to drive our telepalliative care nascent program, which was a pilot.
You know, this work is just so impressive to me. Certainly, hats off to Kevin Murphy and Greg Van de Keefe for leading this effort. It's so powerful and important, and a novel way of delivering palliative care. Telepalliative Care is a new initiative that we've launched that really looks at providing access to subspecialty palliative care to patients in critical access hospitals. These are 25-bed or less hospitals that don't have the capacity to be able to support a full-time, full interdisciplinary palliative care team. But by using technology, we're able to provide services and Zoom from a central location to be able to discuss what matters to patients and families from afar. That we know of, this hasn't been done anywhere else in the country, and certainly improves the ability for us to be able to honor and respect who patients are. But we recognize too that we not only need to do it from our side, but we need to provide resources to families and patients to be able to, for instance, how to make the most of a video visit. We all had to learn early on and continue to learn the best ways to optimize, to use Zoom, to be able to see folks, to be able to understand what their needs are. Now, palliative care as a whole is not just been limited to telepalliative care within our system. I'm very proud to say that we, over the course of the last 2 years, have continued to see a large growth of our palliative care program. Indeed, over the last year in 2020, our palliative care teams amongst 32 different hospitals saved 45,000 bed days by having proactive goals of care conversations, by trying to understand what mattered to patients and families, and then delivering on them, being able to operationalize those in plans. And our palliative practice group has done a tremendous job of being able to support these teams by using different tools, by being able to show their data to them, to being able to give them the ability to see and understand where they have opportunities in terms of the number of consults they see, how early they see folks, and how to think about decreasing the unmet need of palliative care patients within our hospitals. I'm proud to say that over the last number of years, that with the help of the PPG, we have seen palliative care consultations grow tremendously. On this blue line, you'll see the penetration, which is really a measure nationally that's used that looks at how often or what the percent is of the non-OB adult admissions to a hospital are seen by a palliative care team. Nationally, it's about 5%. You'll see that we're approaching 10% across all of Providence. And we're not doing that by burning people out. We're doing that by adding people. We're recognizing that by adding FTE, particularly not just physicians, but also the robust interdisciplinary team, chaplains, nurses, social workers, that we can, by doing that, allow us to be able to grow not only our penetration, but the good work that our palliative care teams do.
Early on in the pandemic, as I mentioned at the top of this talk, we realized that our own well-being was at risk. We are whole persons caring for whole persons, but as whole persons, we are at risk not only of burnout, but of real serious distress. That was recognized, and the heroism of clinicians on the front line was recognized by the general public. We were held up as heroes. People were clapping for us and blowing horns for us, and in Missoula, Montana, howling every night at 8 p.m. for clinicians in town. We realized that this was an opportunity to drive culture change and to engage not just the communities, but the culture of America in learning about deeper lessons of healthcare of clinicians, but also for all of us. One of the things that we've been working on for years has been this Hear Me Now listening program, where we record clips based on a template and model of the great StoryCorps program. We developed a story bank and a listening program of short interviews, about 20 minutes each, of people with clinicians or with family members recounting some story that was meaningful and involved healthcare. During the pandemic, we accelerated development of a podcast based on Hear Me Now. And early on, of course, we focused this on the experience of the pandemic. And here's one where two valued colleagues in Southern California talk about how hard the pandemic was making professional life and indeed their personal well-being. But we use this Hear Me Now podcast through the pandemic to explore critical issues of health, well-being, and social well-being, including things like diversity, equity, and inclusion, social determinants of health. This podcast, which is hosted by Sean Collins, a maestro of radio production. Sean was previously senior producer at All Things Considered, the National Public Radio, national news outlet, and now works with us to develop on twice a month a Hear Me Now podcast. If you haven't heard this, you can find it on any place that you download podcasts. And I promise you, this is a remarkable piece of audio news and cultural exploration. We took on hard topics. Here's my friend Wes Ely, whose book, Every Deeply Drawn Breath, came out this year, and he talked about humanizing the ICU. Dr. Amy Compton Phillips, Dr. Zara Esmail, and Chief Washington Correspondent for Kaiser Health News, previously with NPR, spoke about lessons learned during the pandemic and what lies ahead. And probably one of, if not my very favorite, episodes of Hear Me Now was just 2 weeks ago, when Sean interviewed several people from the Ukraine working on human relief efforts in the Ukraine. And it is just a compelling episode of this podcast. I heartily recommend it to you. This goes on, and the Hear Me Now podcast is available to all across the world, frankly, to explore these issues. The artist Banksy reminded us that this pandemic is cultural. Hopefully, we will never unlearn the heroism of our frontline clinicians, of our nurses, our social workers, but also our direct care workers of nurses' aides, bath aides, dietary folks, housekeeping, all of that. I love this image, this little boy holding up a female nurse, and Batman and Spider-Man are in the basket. This is just so powerful a lesson. This is a moment that should not be wasted. I'll close with this quote from one of our nursing colleagues in Torrance, California. A disease that has put us in isolation has also revealed the resilience of humans. We will never unsee the things we've experienced. We persevere. We cherish life's beauty. We walk a little slower, talk a little longer, hug a little deeper, knowing nothing is permanent. Thank you all for the work you do day in and day out. And thanks very much for taking this time to join us in our first expert series webinar. I hope it's been of value. And I think we've got time to dialogue and take some of your questions. Thanks again.
Hello, doctors. This is Mike Drummond with the Institute for Human Caring. We do have a few questions. I was hoping you guys can entertain them. The first off is about the Get to Know Me posters. The question is, can we use Get to Know Me posters, or are they proprietary?
We would encourage you to use the Get to Know Me posters. If you email us at the Institute, we can send you a printable PDF. We would ask that you keep the Institute for Human Caring logo somewhere on it, but you could also brand it with your own organization's logo as well. Please use it.
I would just amplify too. You know, these posters are so powerful. I've seen them both used in an analog format, and now we're pilot testing them in a digital format, and they just really tell a story that is so powerful and helpful and I would love it if we could get, you know, any single one of you, all of you using these posters, because just photos of who people are in their normal lives outside of hospital gowns, talking about like what matters to people, what their favorite music is, what our favorite movies are. We've heard some incredible stories from our work that really allow people to bond in a different way and recognize the joint humanity. And I think that is healing to all involved. It's healing to patients, it's healing to families, it's healing to our clinicians. Being able to really understand who's in front of us is so powerful.
And we'd be happy to talk with you if you find it's difficult to implement these, or sometimes, I mean, we've been doing this for now years, and not uncommonly, we've had initial resistance or questions from nursing staff or even infection control staff about using these. Well, we've worked through that and listening to their concerns and sharing with them how other hospitals have used these. We've almost always been able to get past the fears and concerns, and then in several of the hospitals, this has really been transformational.
Hey, we have another question from the audience. I don't know if you guys could see it in the chat, but allow me to read it for you. Kind of a hot potato. How were you able to convince budget-minded hospital leadership to support a pop-up Goals of Care center in a busy emergency department during a pandemic, no less?
I can only say we had no resistance whatsoever. We're a mission-driven organization. While we're not perfect, and we certainly have challenges like every other health system, the leadership of this health system believes in the core values of Providence and supported us, helped us to set up these pop-up Goals of Care functionality. There was no resistance at all, and it was not a matter of budget. I mean, you know, budgets were blown anyway during the pandemic, and we were all focusing on trying to give the very best care we possibly could in these unprecedented circumstances. So there's been no resistance whatsoever.
Okay, Matt, did you have to amplify, or you good?
Yeah, it's hard to underscore what you just said. I mean, there was literally no resistance at all. It was the right thing to do. It's important that folks who are in an emergency room with COVID, who are high risk, have conversations about what matters to them so that we can plan. You know, having been in a hospital during the surge last year, people, as those of you know on the front lines know, people decompensated really quickly. And so having conversations early and trying to know what mattered to them, that was just a no-brainer. And it wasn't about money. It was about doing the right thing.
You know, and just to continue this, as I think about this, we were making the service available. We were doing a lot of work to coordinate it and bring clinicians to do this work clinically, and then to work out the technical aspects. But there were champions in the hospitals that we were offering to serve, including, executive nurses within the emergency department that were clamoring for this, that were asking for it. And so, again, there was encouragement, not resistance at all.
Thank you. We've got a couple more if you guys will permit. So here's another one. Impressive data on changes in hospital lengths of stay with early palliative care consultations. The question is, how have you been able to influence clinical staffing levels with these results? I think they're talking about palliative care staffing levels.
So we have shown now 4 years running. We're still waiting for the 5th consecutive years of financial data to finally be closed and analyzed. But we were able to show that when a palliative care team sees the patient within the first Medicare day, which is defined by Medicare as before the second midnight, that when you look at patients of similar disease severity or acuity seen by palliative care before the second midnight and any time after, that those comparable groups, the ones that were seen by palliative care early, spent 4 to 6 days less in the hospital than those seen after. Now, this is not because the outcomes are different. This is really because discharge planning and the plans of care were developed early in a way that provided continuity of care to the outpatient environment. That saves a substantial amount of money in bed days when patients, usually we use the Medicare patients under the DRGs, the diagnosis-related groups, and these patients under DRGs, patients are usually through their financial reimbursement within 4 or 5 days at the most, and if patients stay, 6 or 7 days rather than 11 or 12 days, it's a major advantage financially to the hospital. We're doing it because it's better care. People who are home earlier are less likely, of course, to fall in the hospital or to get C. diff infections or other types of infections. Delirium is also less of a problem if people are home rather than in the hospital. But the costs are the advantages in terms of cost savings, or what's sometimes called cost avoidance, is quite dramatic. So again, showing this to senior level executives year after year have brought them on board. They believe the data. I mean, CFOs, we developed our analyses, our financial impact analyses, working very closely with chief financial officers across the organization. They believe the data. It's their own data. And so, again, it's taken several years, but as they've trusted the data and seen the obvious results, they have come on board to, again, help us to grow the palliative care service line. We're not working in conflict or in tension with them. We're really working collaboratively to grow this service line.
Yeah, I think these analyses are so powerful because it allows us to reinvest in our palliative care workforce, right? We know that patients and families do better when they're seriously ill and they're seen by our palliative care teams. And these analyses allow us to be able to expand our teams, to be able to see more of the hospital. You saw that we're approaching nearly 10% of all adult non-OB admissions are seen by our palliative care teams, when the national, figure is about 5%. We're not doing that by working people harder, as I think you saw. We're doing that by reinvesting in our workforce, allowing them to have time to do the things that they need to do and to have great conversations with folks and to manage their symptoms. So it's honestly a pleasure to see and to be able to watch these teams grow, both in the size of the teams that we have and their expertise.
Hey, I wanted to share a comment that's in the chat here. It's from Patty Fogelman. I just want to thank you all for lighting the way forward through one of the scariest times in modern medicine. Sharing information so freely, such as the Get to Know Me posters, is incredible. I implemented them in our COVID ICU and regular ICUs. The impact this makes on families, especially when we complete them together with the family at visitation, is deep, meaningful, and so valuable. Thank you for being a true North Star in all of this. Well, thank you, Patty. That was kind. We have a couple more questions from the audience, and we have some time. So let's get to it. Let me see. How about this one? How was the determination of 5 days plus in the ICU made? I guess what they're asking is, why did you select 5 days?
Good question. I will take that, but before I do, I just want to acknowledge, Mike, what you just read from Patty. You know, I am proud of the work that we've done at the Institute for Human Caring, but I'm equally, if not more, proud of the response of the clinicians on the front line across Providence. It is astounding, the work that you all have done. You know, I volunteered for a brief 6 weeks last year to be able to help out during one of the surges in LA, and it was hard. And so what I would say is thank you all, because that our society, people we love have all benefited from the care, from the true human kindness that you've shown. And so I'm proud of the work we've done, and thank you for the kudos. I see our job really as enabling the care you all provide to be as good as it can be. So I will start there. The question about ICU is a great question, Mike. You know, 5 days is not the, I think, perfect number. A lot of folks have said, well, you know, 5 days in an ICU, like that is way down the road. Wouldn't it be better if you had goals of care conversations on admission to the ICU, or when somebody is coming into the ER and, you know, their vitals are a little bit soft and you're not quite sure which way they're going to go? We started with the sickest of the sick because, you know, truly there was a backup by critical care societies to be able to use this, but we are moving the dial forward. We are trying to get these goals of care conversations upstream. So we're having conversations with the acute care leadership, with the cancer groups, with the heart failure groups, trying to say these conversations shouldn't be in just the sickest of the sick. We need to make sure that people who have a new diagnosis of stage 3 cancer, or who have a new diagnosis of heart failure, or who are getting admitted and their risk of readmission because of everything that they've been through is very high, we need to start having these conversations early and often.
Can I just amplify that within the critical care literature, which has been very strong about the importance of shared decision-making, goals of care conversations, goal alignment, you can find recommendations, expert opinions or consensus statements that go anywhere from the first on admission to 3 days to 7 days. We chose 5 days because it has real face validity. I mean, nobody can say, well, if you know, that wasn't necessary before 5 days. Well, at 5 days, you know, if you're still in an ICU, there ought to be a goals of care conversations. We realize that 3 days still might be a little bit early for some ICUs. Use their ICU to recover cardiac patients, you know, transplant or valve surgery patients. And so those patients' goals of care have been set in the outpatient environment and may not need to have been refreshed. The other thing that I would say is that while that 5-day metric was well accepted, that we have designed that performance metric not to require the critical care team or doctors to do it. It can be done by the patient's hospital medicine team if the patient was in the on the medical floor prior to going to the ICU, or the surgical team prior to going to the ICU, or even their primary care physician who might come into the hospital to have that conversation, or that these days even Zoom in to have a goals of care conversation. It's person-centered. It's not necessary to determine who does it. It's rather, was it done with a patient or the patient's family in a way that was meaningful? And we've set some min-specs criteria for what a goals of care documentation note looks like, but it's pretty basic stuff. And we're focusing on having and recording an actual conversation about what's achievable and then what the patient's values, preferences, and priorities are.
We could talk about this forever. I have one more thought around this, which is, you know, I said early on that we had 43,000 of these conversations last year, which is impressive. I want to put that in context, which is, if you look at our population of folks who had an ICU length of stay of 5 days or more, across Providence, 62% of them had a goals of care conversation in their chart that was recorded. And frankly, I think that's remarkable. Yes, I would love it to be at 90. I would love it to be at 100%. But when we started this journey, we had 1,200 conversations in a system of this size just 5 years ago. And that growth is exponential and wonderful. And I'm looking forward to it continuing to grow.
You know, our sustainability strategy within the Institute for Human Caring is to create new normals, to lift from current state to future state. And what we're seeing is we're beginning to see the future of goals of care conversations and goal alignment being the new normal. People in certain hospitals around our system will say, well, that's just what we do here, right? It's beginning to be the basic expectation, and that provides us with real sustainability of this value-based, quality-based culture change.
Wonderful, you guys. Hey, we're almost at time, but I would like to squeeze in one more question, and this is from Anonymous, and it goes like this. How can we get hospitalist providers support to allow trained clinicians to hold ethical, unbiased conversations with patients early in their progressive illness, to learn their values and priorities, even while they're worrying this will impact their treatment plan?
Well, hopefully it'll impact their treatment plan. It'll make their treatment plan more in alignment with what matters most to the patients that we are serving. So, you know, we've shown you the metric for goals of care conversations for ICUs stays of 5 or more days, but that is by no means the only teams or specialty service line we're working with to socialize and normalize goals of care conversations. It's happening in the primary care level. It's happening with oncology, cardiology, hospital medicine, and the like. Again, person-centered. So we are making it just the new normal, and part of the definition of quality in Providence is documented good faith efforts to do what people value and what matters most.
Yeah, I really hope and believe that it's becoming a standard across Providence, that we're having these conversations. You know, I have family members that have been sick over the last few years, and they haven't had these conversations after a long hospital stay. And it is hard on patients and families when we're not talking about these important things. For me, I hope that our team continues to reduce the barriers, because I recognize that we still have growth. We still have places where maybe these conversations aren't happening as frequently as we'd like. But if that's true, reach out, talk to us. Let's figure out how to break those barriers down together, because I think that at the end of the day, all of us want to be able to provide the best care possible for our patients and families, and that includes having great conversations with them to understand what matters to them.
Wonderful, doctors. Thank you so much. Well, that brings us to the end of our first in a series of webinars, expert series webinars this year. Our next one will be in June. Please stay tuned. You can follow us on Twitter, human_caring, or check our website out at instituteforhumancaring.org. And if you post to social, please use the hashtags #transformhealthcare or #wholepersoncare. Thank you. Be good to yourselves and each other.
Thank you all.
Thanks.